Good evening, everybody, and welcome to our webinar on vaginal prolapse treatments. My name is Chaseley, and I'm the clinical nurse specialist here at Benenden Hospital. Our expert presenter today is consultant urogynaecologist, Mr. Abhishek Gupta. This presentation will be followed by a question and answer session. If you'd like to ask any questions during or after the presentation, please do so by using the Q&A icon, which is on the bottom of your screen. This can be done with or without leaving your name. And please note this session is being recorded if you do provide your name. If you would like to book a consultation, we'll provide contact details at the end of this session. I'll now hand over to Mr. Gupta, and you'll hear from me again shortly.
Thank you, Jeff. So that's a brief summary of who I am. So my name is Mr. Abhishek Gupta. I'm a consultant gynecologist, and I'm a urogynecologist who has a special interest in incontinence and prolapse, and I do a fair amount of keyhole surgery operations as well. I'm my NHS based in the Benenden Hospital. I'm a lead urogynecologist there. I did my advanced training in urogynecology and laparoscopic surgery, and I'm a Southeast London rotation trainee, and I've been providing care for the patient and services in urogynecology in Benenden Hospital for almost 11 years now, and I'm a member of British Society of Urogynecology as well as urology for obstetrician and gynecology. So that's brief background of who I am. So this session is mainly aimed for prolapse. So we have done a session in past for incontinence, and we might do it again in future, but this session is more for pelvic organ prolapse. So what we want to cover in this session is what are the symptoms of pelvic organ prolapse, then what are the treatment, what do you mean by pelvic floor exercises, and Jan will take you through what pelvic floor exercises are. Then we will touch base on bit of treatment of estrogen vaginally, and I'll try to explain about how it helps and what are the side effects and which cases to avoid and which cases not to avoid. And then we'll touch base on surgical treatment, and at the end of the session we'll have a question and answer. And you're more than welcome to put your question in the chat, and we'll try to answer as many as possible towards the end of the session. So what is pelvic organ prolapse? So this is a two-dimensional picture. So if you look from woman from front to back, the first thing you notice is bladder, which is the first thing you notice behind your bone, and the bladder, then the tube which drains water out, which is called urethra. Just behind that, you will find the womb, then the vagina, and then behind that will be the back passage. So that's the human anatomy. So prolapse is basically a hernia through because of the weakness of the tissues. When it comes in the front wall, the bladder starts to protrude in the front wall, which is called cystocele. If the top is coming down, which is the neck of the womb, and if you have a hysterectomy for some reason or the other, that would be top of the vagina. When it starts to descend or come down in the vagina, that's called either a womb prolapse, or that's called a vault prolapse if you had a hysterectomy. And the prolapse is coming from the back of the vagina, then it is mainly the bowel which is trying to push into the vagina, which is called rectocele. So front wall, cystocele. Middle compartment is either womb prolapse, which is uterine prolapse, or the top of the vagina, which is called vault prolapse. Back wall is the rectocele or the bowel prolapse to the back wall. So this is what the prolapse is. What are the causes of prolapse? It's mainly the weakness of the tissues, which is the weakness in the muscles that supports the vagina and surrounding organ, which causes a prolapse. And the main risk factor for prolapse, obviously, childbirth, or if you have previous instrumental deliveries. I think that causes quite a bit of trauma to pelvic floor. Then repetitive straining, like if you suffer from chronic constipation, or you lift heavy weights, or you have chronic cough. Then menopause also causes a lot of menopause does have an effect on your supporting structure, and it does make it weaker, and it can cause weakness in the supporting tissues or ligaments, and this can cause increase your chance of prolapse. And then, unfortunately, all of us are going to get older. We're not going to get younger, and when we get older, our tissues do get weak, and that causes prolapse. Previous history of hysterectomy for benign reasons, that does increase your chance of prolapse in future. And then if you're obese, so weight does affect a lot of pelvic organ, because if you can imagine the obesity, the whole weight you're carrying is going through your pelvis, and that makes things weak. Things like smoking doesn't help. Smoking does have a lot of effect on the collagen, makes it weaker, and cause you to have an increased risk factor for a prolapse. So smoking is not good for any supportive tissues of the body. So these are the rough reasons why people have the prolapse. What are the symptoms of pelvic organ prolapse? So main symptoms you feel is the heaviness or feeling of bulge in the vaginal area. Prolapse usually doesn't cause pain. So pain is usually not caused because of prolapse. It causes discomfort, a dragging feeling. You may notice that something is coming out of vagina, like a ball. So you might feel a lump. Usually, if you are on your feet for a long time, the gravity acts, and the gravity can make your symptoms worse. So the prolapse can feel worse, or a lump of feeling can go worse towards the end of the day, which is because of the gravity. Usually when you lie down, then your prolapse symptoms should get better because the gravity is not acting. So that is important. Some of the patients do get a lot of pain in vaginal area or the pelvic area, and they get it in the night. That usually doesn't happen because of prolapse. The prolapse is usually uncomfortable during the daytime, and in nighttime things do get better. Sometimes it can cause discomfort during sexual intercourse. Bladder, if you remember my previous slides, if the bladder is bulging into the vagina, it creates a little pouch, and sometimes you find it difficult to empty your bladder completely. So it might happen that you go for waterworks, you empty your bladder, then you get up, and then you feel that, oh, I've not emptied my bladder completely, because there is still a bit of water left in your bladder, which has created a little pouch in the vagina because of prolapse. You get up, you feel I've not completed, and then you go back and empty the bladder again. Sometimes it can happen because of the prolapse in the back of the vagina. When your bowel gets full, rather than coming out to the back passage, it forms a little bulge or a lump in the vagina, and then it makes you uncomfortable. And occasionally people have to digitate or have to assist themselves, if I may explain, assist themselves through the vagina, which is splinting to empty those. So that reduces the bulge, and then it empties the bowel better. So prolapse can cause difficulty in emptying the bladder, and if the prolapse is from the back of the vagina, sometimes it also causes difficulty in emptying the bowel. And urinary incontinence can happen, but it's usually more of a support structure failure at the neck of the bladder level rather than the bladder itself, and that's slightly difficult to quantify whether you have a prolapse only for the bladder, but you also have a prolapse at the neck of or weakness at the neck of the bladder level, which is causing the leak. So treatment of pelvic organ prolapse. So very important for us to understand, this is all about quality of life. So just because anybody has a prolapse doesn't mean that this needs treatment. So it really depends on your quality of life. So you may go to your practice nurse, who might do a smear on you and then say, oh, I can see a bit of prolapse. So any woman who have given birth vaginally or had an instrumental delivery will have some kind of weakness of pelvic floor. But that doesn't need a treatment until unless it starts to affect your quality of life. And your quality of life may be different than your friend's quality of life or someone else's quality of life. So what is bothering you up? What is stopping you doing, or how much discomfort it's causing you? That's when it needs treatment. So obviously, if you have a problem, your GP might refer you for further tests. We usually look for infections in the urine if you have symptoms. occasionally we have to have a look inside the bladder if it's causing you a lot of urgency. But if you have a mild prolapse, which is, there are 4 stages of prolapse. Stage 1 is when it's the starting of prolapse, but the prolapse has only reached up to 50% of the vagina opening, but not below. Second stage is 50% of vagina to the opening of the vaginal orifice, but not coming off the body. Stage 3, when the prolapse has started coming off to the body, and stage 4, which is what is called procedentia, when the prolapse has started to come out completely out of your body. That's called stage 4 prolapse. So if you have a mild prolapse and no symptoms, you don't need any medical treatment. Lifestyle changes may be all you need. Losing weight if you're overweight, avoiding lifting heavy weights, constipation, that's really not good for you, because if you strain, you will make that worse. And then pelvic floor exercises. I think pelvic floor exercises is so important for patients who have either mild or moderate prolapse, or even if patients have got a large prolapse and need any surgical treatment or any pessary treatment in future, pelvic floor exercises will prevent the recurrence of this happening in future. So I think pelvic floor exercises, especially if you've given birth and you're a young woman, you should start pelvic floor exercises sooner than later so that you can build up the muscles for future. And then if you are menopausal, some hormone treatment will help. And obviously, if the prolapse then becomes symptomatic, then we consider vaginal pessaries or doing surgeries later on. So I'll leave it to Jan now to talk a bit more about herself, as well as pelvic floor exercises, which is first main stage treatment for pelvic floor for prolapse. And then if it doesn't work, then we obviously have pessaries or surgical treatment, but I'll hand over to Jan now.
Lovely, thank you, Abby. So my name is Jan. I've been managing the specialist nurse team here at Benenden for the last 15 years. And we run nurse-led clinics here at Benenden to see patients either with incontinence or patients with prolapse. So what will happen at your appointment? So if your GP does a referral here and is mentioning in his letter, as he will do, that you've got symptoms of prolapse, you will most probably come to the specialist nurses as your first appointment here at Benenden. And the idea of that is we can undertake all the tests, we can assess you, we can get you going with the pelvic floor exercises that Mr. Gupta's talked about, and hopefully everything that we do is going to be enough to manage your symptoms. And if when we review you after that, you're still symptomatic, at that point, you will then be referred on to see the consultant. So after taking sort of a history, and we want to know what symptoms have you got, how bothersome are those? Are they affecting your bladder? So we will test your urine. Sometimes symptoms of a urine infection can be your first indicator that actually you've got sort of some asymptomatic prolapse. If you are having problems with your bladder, we'll do a flow rate. We'll just get you to pass urine on a special sort of measuring commode, and we'll scan your bladder afterwards to check how that bladder's emptying out. We'll probably get you to complete a 3-day bladder diary, and that's really important. It shows us what you're drinking, but more importantly, how often you're emptying your bladder, and how much urine you're passing. So it could be that you've got a good fluid intake, but you're emptying the bladder very frequently with small volumes. And if you continue with that over time, then obviously it's going to affect how your bladder is emptying. If constipation's an issue, we'll give you a sort of dietary advice as well. We'll work on the bladder retraining. So again, looking at what's going on your bladder diary. Ideally, you should be drinking around about 2 litres of fluid in a day. And on the back of that, probably emptying your bladder about every 3 hours as a rough guide. So if you're listening to this and thinking, oh, actually, I'm in that toilet every hour, or, oh my God, I probably only go 3 or 4 times a day, then actually, even if you haven't got prolapse, just get yourself into good habits with your bladder so you're not storing up any problems for later life. We'll assess your pelvic floor and we'll get you going with structured individual pelvic floor muscle exercises. And it's very easy to sometimes do those exercises incorrectly. And if you're doing that with prolapse, you could potentially make your symptoms worse. So it's always worth having a proper assessment with the specialist nurses. Again, as I said earlier, we'll help you manage any constipation, speaking to your GP, adding in any laxatives if we need to. And obviously look at weight loss, as Mr. Gupta said, you know, if you're carrying excess weight, that's more pressure onto that pelvic floor. And we'll give you advice about exercises. Obviously, sort of if you get to be a menopausal woman, it's really important to still be doing things like weight-bearing exercise. But if you've got prolapse, you want to avoid doing anything that's going to give you too much in the way of squats, too much squatting and heavy weight. So we'll help you manage all of that. Thank you, Abby. So pelvic floor exercises. So your pelvic floor muscle is made up of what they call strong muscle fibers and fast muscle fibers. So it's really important when you exercise your pelvic floor that you're working both of those muscles. If you've got prolapse, we want to focus probably slightly more on the strong contractions because we want to build that strength and support of your muscle. But it's really important, you know, to do both of these. So when you're contracting your pelvic floor, it's all about just squeezing the muscles underneath, as if you almost feel you're squeezing to stop passing wind, and also squeezing to feel you're trying to squeeze to stop emptying your bladder. It's not about pulling in your tummy. It's definitely not about holding your breath, because then you've got energy up here and you want all of that work to be going on underneath. If you stand in front of a full-length mirror and you squeeze your pelvic floor muscle, you should still look exactly the same, because all of the work is going on internally. And that's the sort of thing that as a specialist nurses, we can help you with. So if you're looking at doing what we call the fast contractions, it's about squeezing that muscle up while you count to 1, and then you just relax it for a count of 1. So it's literally just squeeze it up, relax it down, squeeze up, relax it down. And we normally advise to do 10 of those at a time, a couple of times a day. So then we're looking at the strong contractions to build that strength and support to try and help support that prolapse and stop things getting worse. Initially, you may only be able to squeeze and hold for 2 or 3 seconds, but we'll work with you and we'll try and come up with an individual program and very slowly start to strengthen those muscles up for you. If you're following national guidelines, which we do, the National Institute for Health and Care Excellence, they advise good structured pelvic floor muscle exercises as a first-line treatment for prolapse for at least 3 to 4 months. So we will see you and assess you, send you away with your exercises, and then we will either see you back face-to-face in the clinic or give you a telephone call at around about sort of 3.5 months to just see how things are going. Hopefully things are better and we can discharge you, but if they're not, then obviously we can move you on to the consultants. But the important message of that, I think, is if you're doing your pelvic floor and you don't think they're helping, don't give up, keep going. It's really important.
And for future as well, even if you have an operation, and none of the operations are foolproof, the prolapse can come back in future. So if you build up good pelvic floor and a habit, I think post-operatively as well, you'll get the maximum benefit and less likelihood of things coming down again. So I think this part is really important.
Yeah, it is really important, yes.
So hormones. So we're talking about only estrogen in the vaginal hormones at this point of time, because the prolapse, especially when you have gone into menopause and you've got any symptoms of prolapse or vaginal discomfort, which may or may not be because of prolapse. If you have vaginal discomfort, or if you're going to have you got prolapse which needs surgery, or even if you have prolapse, you need a pessary treatment, or if you do pelvic exercises and you're menopausal, the hormone cream in vaginal areas of vaginal pessaries are so important. So what that does is it builds up the skin. And sometimes because of lack of hormones, the vaginal tissues go very thin, and they can itself give you a lot of dragging feeling, a lot of discomfort, and a lot of discomfort, and also this can give you pain. It can predispose you. Lack of hormones can predispose you for increased risk of water infection, and therefore, I think there is a condition called vulvovaginal atrophy, which is lack of hormones in the vaginal area after menopause, and it can cause all sorts of symptoms. So vaginal hormones come with either with a pessary, which is like just a small tablet, which an applicator which comes in you can put in the vagina, and usually the treatment is You use it every night for 2 weeks, then twice weekly as a maintenance. It also keeps with a cream. So similarly with an applicator, you put in the vagina every night for 2 weeks, then twice weekly. And there is also a string, which is the pessary, which goes in the vagina, and then it secretes the hormones on a regular basis. A lot of patients have a bit of myth, and obviously if you read through the the literature comes with it, it tells you that this is all about HRT. Yes, having estrogen is always a part of HRT, but this is a local cream or a local pessary. So the amount of hormone which comes in your bloodstream is minimal, and hence it doesn't have that kind of side effects. So only patients I say to avoid estrogen in the vagina are either having a vaginal bleeding when you have a uterus and it has a vaginal bleeding which has not been investigated. Hence, we need to investigate the lining of the womb. If you don't have any vaginal bleeding, then you can have this estrogen. Only a very small patients who have breast cancer, then which are obviously breast cancer has been treated already and you've been discharged. Even those patients can have a short course of estrogen if we have a discussion with your oncologist or surgeon. Otherwise, apart from this two, there is no other contraindication of having a vaginal estrogen. So I think this is very safe, and amount which comes, as I said, comes in the bloodstream is so little, and it's got a lot of good effect on which patients' vaginal health and your symptom treatment. So I usually recommend patients to have vaginal estrogen if they have symptomatic of prolapse or even other things like recurrent urinary tract infection or discomfort in the vaginal area after they go into menopause. Then, so you've done the pelvic exercises, you've done a bit of hormones. Then if things are not getting better or your symptoms are quite, it's affecting your quality of life, then the options are then at that stage either to have an operation or try vaginal pessaries. So they come in various sizes, and there are two kinds of pessaries. One is made up of PVC, which needs to be changed every 4 to 6 months. And one is made of silicone, which again has to be examined by a GP or your healthcare professional in 4 to 6 months' time, but don't necessarily need a change. They may be brought out after checking, maybe washed and reinserted. And they come in various sizes. The ring pest and depends on whether you have the womb or what kind of prolapse you have. One pessary may be more suitable than others. And it's a healthcare professional. We have to decide which is better for you. Usually, if you're sexually active, we used to use the ring pessary, which is on the top left, but we'll have to teach you how to bring it out yourself and then insert after you have the sexual activity. Otherwise, the other pessaries, which are the donut, which is on the right, top right, and then ring pessary with the support, which is on the bottom left, and also the gel-on pessary, which is on the right side on the bottom on the right. This pessary is usually very difficult for patients to maintain themselves. And if you're sexually active, we don't usually use those. It works on on 50% of the patients. So there are 50% of the patients the pessaries don't work, and there's common causes of discontinuation are either it comes out. So if your muscles are not strong enough and to hold them in place, they can come out. So that's one reason for discontinuation of pessaries. It can be uncomfortable. That can be the second reason. Sometimes it gives you a lot of vaginal discharge on patients and it can be unpleasant. Occasionally it can cause infection, and then sometimes it can cause pressure effect, which cause bleeding. So, and then it can put pressure on your bladder, and sometimes pessary itself can cause urgency of waterworks. And they are the common reasons for it not to work. But if this does work on you, it's 50% of the patients are happy with the pessaries. Then we are thinking about surgical options. So when you consider surgery, again, as I said, the prolapse needs surgical option if it does affect your quality of life. And what are the goal of the operation? The goal of the operation is to ensure we can support the prolapsing organ, and that's the goal. Some bulge or small amount of bulge may still remain in place because it's difficult to correct a prolapse to where you had to an original condition when you had no children, there was no prolapse, your support structures were completely intact, those expectations are difficult to achieve. But as long as your quality of life gets better, the prolapse, sometimes when prolapse is coming out of your body, it goes in and your quality of life is better. That's the main aim for doing the reconstruction procedure, is to give you better quality of life. And the function should get better. So if you're not able to empty your bladder because of cystocele, which is bladder prolapsing, you're not able to empty the bowel because bowel is back passage is prolapsing. Once we correct that, hopefully it will give you more symptomatic correction and your functions get better. So that's the aim for doing the operation. So we usually try to avoid meshes, and we do more of a repair from your own tissues. So for the prolapse of your bladder, we do what is called colporrhaphy, which is anterior colporrhaphy, where we open the front wall, push the bladder back where it's supposed to be, bring your tissues, supporting tissues together, and suture this up. And with time, the scar will form, and that will give you a platform so that the bladder doesn't prolapse back in. Similarly, if your bowel is prolapsing, we do the same thing on the back. We open that area, push the bowel back in, bring the supporting muscles together, and suture it up. And that support happens. If the womb is coming down, then the commonest operation I do is vaginal hysterectomy, which is taking the womb and the neck of the womb out if the womb is prolapsing. There are alternatives to hysterectomy, which is either doing mesh, which is called sacrocolpopexy or sacrohystopexy, which is go through the tummy and put a mesh in. Now, meshes are under high vigilance restriction nationally. We don't do mesh surgeries here because it's fairly, it's fairly okay to do mesh operation, but if there is a complications, now with the new rules, we are not allowed to do the mesh complication deal with, and they're supposed to be referred to the mesh centers. And hence we try to avoid doing any mesh operations, because if there is any issues, we can't nowadays, because we can't do we are not allowed to trim the meshes or repair or take the meshes out, and they all have to go to UCLH, which is our mesh center. So hence we try to avoid meshes, just because if there is a problem, we find ourselves in a position that we can't deal with the mesh complications. So we try to avoid mesh operations. Alternatively, if you still want to have more children and the womb is coming down, or some people like to keep their womb, we can refix the womb with a fixation or suspension, which is called sacrospinous fixation, where we can reattach either the neck of the womb if you still have the womb, or we can reattach the top of the vagina if you already had a hysterectomy and top of the vagina is coming down to a strong ligament, which is called sacrospinous fixation, which is through the vagina. It's a quite invasive surgery. You haven't, either with a repair combined with a hysterectomy or a sacrospinous fixation, the hospital stay is usually 1 to 2 nights. Complete recovery will take 6 to 8 weeks. Risk involved is small risk of infection and bleeding. And because we operate so near to organs like bowel, bladder, there's a very small risk of injury to these organs. When I say small, it's less than 1%. And the plan is to do all the operation through the vagina, but only in case of complication, we either have to do a keyhole surgery, cut in the tummy to repair it up. After we have done the treatment for prolapse, we always advise our patients not to lift heavy weights, to not get constipated, because prolapse can come back again. So very important. And that's why I was saying, once we've done the operation, usually once I've done the operation, my follow-ups is done by Jan and her team. So you will be assessed that the operation has gone well, healing has gone better. If there is obviously an ongoing concern, then I'll see you back in the clinic. But majority of patients are absolutely fine after the operation. Jan and team does a follow-up, then they will go through the pelvic floor exercises with you, bladder retraining with you, so that in long term, we give you kind of a holistic care for pre-op, operation, and the post-op care, so that it reduces the chance of having reoccurrence in future, because 1 in 3 women may need this surgery done in future. That's a kind of because of recurrence of prolapse risk, which is kind of what is noted in literature. So it's quite a high risk if you look into it, of 1 in 3 in 10 women. 1 to 3 in 10 women might need this surgery repeated in future. So hence, the post-op care and post-op pelvic floor exercises and optimizing weight as well as non-smoking in the future, then not lifting heavy weights, avoiding constipation are equally very important. So this is what I've thought about. This is mainly if the womb is coming down, then hysterectomy is an option, mesh is an option. We just had a discussion about it. And in some cases, when everything is failed or you're completely unfit for a surgery, some patients are medically very unfit for a surgery, and pessary hasn't worked, and they've got quite a big prolapse, then we resort to our last option, which is called obliterative surgery, which is basically we close the vagina. In that case, you can't have sexual intercourse, but there's still a channel to empty the bladder. But we close the vagina, and that's really is a last resort if operations have failed or you're absolutely unsafe. You're not unsafe, you're unfit to have any surgery and you've got a big prolapse. That's called obliterative surgery. So obviously, surgery is not risk-free. I've briefly explained what surgical risk involves. So you will either have this surgery either with a spinal anesthetic or general anesthetic. Very rarely, if you have a major surgery, especially hysterectomy or sacrospinous fixation, then there is a risk of blood transfusion. How often it happens? It happens to 1 in 300 patients approximately. We talk about damage of the surrounding organs, which is bowel and bladder, which again happen in around 1 in 100 patients. Infection is the main risk. We do give a shot of antibiotic while you're in theater. However, because if you imagine that area is very close to your back passage, which is where full of germs are, therefore it's more susceptible to have infection after vaginal operation, and hence we ask you to keep it clean. As you can imagine, any operation heals with scarring. Sometimes the scar can cause pain during intercourse, which is called dyspareunia. Usually settles on its own. Occasionally, we may have to take a patient back to theater to divide the scar tissue. How often it happens to us? Every year or so, I'll have 1 or 2 patients. I may have to divide the scar tissue. Some discharge or bleeding is expected after the operation still when the stitches are dissolving. All the stitches we put are dissolving stitches. So when they dissolve, it can cause a bit of discharge. Usually things do settle in 6 to 8 weeks time. And as I said, the prolapse can come back in future. We give you a blood thinner after the operation to prevent what is called DVT or clot in the risk, because that can happen with any surgery. So you usually stay in hospital for 1 to 2 nights. They give you some fluid and you will have a catheter draining your waters, which usually comes out next day. We put a little pack, which is a gauze, which helps to stop the small bleeders, which is usually overnight, which again comes out next day. You may have, as we said, some vaginal discharge and a bit of bleeding for next 3 to 4 weeks when the stitches are then starting to come out and dissolve. In 6 weeks time, usually things do settle down. We try to mobilize you sooner than later. So we want you to not to be on the bed in bed rest for a long time. We start mobilizing the patient pretty much on the same day or the next day, because and this is not vigorous exercises, mobilization, which we want to really promote patients to mobilize rather than on the bed. We try to ask you to avoid taking bath for soaking those tissues, those stitches for a long time, but you can have a normal shower. Avoid swimming for 4 to 6 weeks if you can, because the stitches, you don't want them to dissolve very soon. But a quick shower is absolutely acceptable. The sexual intercourse, obviously, we ask you to avoid for 6 to 8 weeks, because you will be uncomfortable, and obviously the stitches have not healed up properly and scar tissue has not formed. And depending on what kind of work you do, we usually anticipate that after a prolapse surgery in 4 to 6 weeks time, you should be able to go back to work. But if your work is quite strenuous and lifting heavy weight, you might have to go on a phased return back to your work. But if your work is more of working from home, or it's a less physically strenuous job, then you may be able to return to work sooner. That concludes in a brief what prolapse, cause of the prolapse, what symptoms are, what investigation we do, how we treat. And I will hand over to Jan. If you have any further question, please feel free to put on the chat.
Lovely. Thank you very much, Mr. Gupta. That was a very informative presentation. And at the moment, we only have one question. So it looks like you've answered everybody's question.
That's your question.
As we went along. So the first question we've got is, are there any exercises you can do to prevent prolapse? So obviously, we've talked quite extensively about the importance of doing those pelvic floor exercises. Also, I often recommend Pilates. Pilates is very good. It's very good at engaging your core muscles, and anything that is engaging your core muscles is also then engaging your pelvic floor. But I would also suggest that you find yourself sort of a qualified Pilates teacher, and you don't just sort of do something off the internet, just in case you then find you're doing the wrong thing and potentially making prolapse symptoms worse. So a question for Mr. Gupta. How long after surgery can you drive?
So usually we ask you not to drive for 3 to 4 weeks, and after that, if you feel that you are able to do an emergency stop, then usually 4 weeks is the time frame when we say you can start driving if you can do an emergency stop. But usually people should be okay to drive after 4 weeks, or if you're still having a bit of soreness, then 6 weeks. But I usually ask you to check with your insurance company that they don't have any limit to when they allow you to start driving, but usually we say around 4 weeks.
Thank you. Is there a time limit for using vaginal estrogens? So
if you have a history of breast cancer, then if it's okayed by your your oncologist, they usually ask you to give a short term of 6 to 8 weeks. Otherwise, once you start the vaginal estrogen, I recommend that if you're treating then daily for 2 weeks, then the maintenance is twice weekly. And I often ask GPs to put twice weekly on your repeat prescription, because once you stop estrogen, then you go back to where you started from. And twice weekly is even small dose, but it does the work of keeping the vaginal tissues healthy, and it reduces your chance of developing the vulvovaginal atrophy. So it keeps maintaining your vaginal health, and that I think you can keep it on a repeat prescription.
Thank you. What is the percentage of chronic pain after sacrospinous fixation surgery?
So the pain usually settles down. Mainly it's the buttock pain, which happens after sacrospinous fixation, which usually settles down with time, especially when the stitches have dissolved. Occasionally, we may have to put a permanent stitch in case your prolapse has come back again, or your tissues are not really good. And if you're if you're in an advanced age, then sometimes you put a permanent stitch as well. However, the chronic pain is usually, I would say, roughly around 1% of the patients, but we don't often see chronic pain after sacrospinous fixation nowadays. It used to be more before, because we used to use a device called Maya hook to do this operation, which was quite a big device beforehand. But nowadays we use what is called a capio device, and capios are much smaller devices, and they're much more gentler to the tissues, which can use less chronic pain. So I would say if the chronic pain happens, is usually in around 1%, but majority of buttock pain usually subside in 6 to 8 weeks time, or 3 months, while the time PDS stitches do dissolve. Because even if you use the dissolving stitches, we use a PDS stitch, which takes around 3 months to dissolve. And usually in 3 months time, the buttock pain does subside. So chronic pain is around 1% approximately.
And what are the complications of repeating prolapse surgery?
Complications are the same, but the results of repeating a prolapse surgery is less better than first time round. Complications are the same as of any prolapse surgery. However, the complication can increase if you are having a repeat operation, because obviously scarring makes operations more difficult to do, and more operations you have are less effective, and there's slightly increased chance of the complication. The complications are essentially the same, but the risk increases with more operation you have on the same site.
Thank you. And how would you decide if it's a spinal or general anaesthetic?
I usually leave this discussion with the anesthetist to have with you, whether it's a spinal or general anesthetic. So it's usually not my decision. It's decision between patient and anesthetic. For the repair surgery, I think general anesthetic is absolutely fine. For if you're having a hysterectomy, again, I mean, this is a hysterectomy we're doing for prolapse, but there is enough of literature out there that even if you're having a hysterectomy for other reasons, not prolapse, then between a laparoscopic hysterectomy, open hysterectomy, and vaginal hysterectomy has got the quickest recovery, least pain, and shortest hospital stay with least complication. And even the vaginal hysterectomy is fine with general anesthetic, but that's borderline when some of the anesthetists feel that spinal anesthetic might be better for a long-term pain relief. But if you're having a sacrospinous fixation, which is slightly more invasive than, and somebody rightly asked about what's the reason causes for the pain, then I would say the spinal anesthetic will work better than having a general anesthetic, or you can have a combination of the spinal anesthetic and general anesthetic on that cases.
Thank you. And there's a couple of questions about yoga. Is it all right to do yoga with a stage 3 prolapse? And is yoga as good as Pilates to strengthen core muscles? So my advice on that would be, yeah, if you're doing yoga, again, yoga is very good. If you have a stage 3 prolapse, you want to be cautious that you're not sort of doing too much in the way of sort of bending or squatting. Something probably, you know, lying down with your legs up the wall would be a good relaxation thing to do as well if your prolapse was slightly bothersome. And have you got any advice around sort of yoga or any exercises to avoid?
No, yogas and Pilates are all good, but be mindful that yoga and Pilates are not pelvic floor exercises. It's good for core muscles, but they may not necessarily be directed towards pelvic floor, but they're low impact exercises, and they are good to have to do even if you have prolapse, or even if you have a prolapse surgery. So I think yoga and Pilates you won't go wrong with. Yeah,
I'd agree with that as well. And Mr. Gupta, would you advise women who are in the menopause who have prolapse to have estrogens?
I would. I think vaginal, I strongly believe, and maybe because I'm in this profession for a long time and see patients, so I may have a slightly biased view on this, because I see the problems. I think women's vaginal health is underreported after menopause, and I think it needs more care than what is out there in community and offered. So I strongly believe that if patient has gone menopause and they're symptomatic, vaginal estrogen do has a role to play.
Yeah, definitely. And I think sort of sometimes in GP practices, you know, there's some grey area. They don't seem to think that women should have it or should have it long term, and it's completely safe. It's marketed to be used for long term. It's such a low dose now.
And now it's more awareness, and it's been licensed to be used for long term now.
Yeah, thank you. And a question from a lady, she says she's 65 years old. She's got a grade 1 to 2 prolapse. And what would you consider as normal? And I think, as Mr. Gupta said in the beginning of his presentation, quite often people maybe have a bit of grade 1 prolapse. It can be completely asymptomatic, might only be picked up on smear tests. Obviously, maybe not so much as you get obviously older and they're not carried out. But I would just sort of say, you know, actually, if you're not aware you've got a prolapse or you feel you've got mild symptoms, do your pelvic floor exercises, speak to your GP about some vaginal estrogens. And it's difficult to say what would be normal because every patient is different. Thank you. So another question, if a ring pessary will support the prolapse at a time, will it prevent it prolapsing further?
So the ring pessaries are not for stopping the prolapse to get worsened. So important thing is ring pessaries are not, or any pessaries are not to stop the prolapse getting worse. Ring pessaries only, or any prolapse is only symptomatic correction of the prolapse to keep the prolapse in place or inside the vagina. They're not used to prevent prolapse getting worse in the future, or their treatment of prolapse. There's just a symptomatic correction of the prolapse you've already got.
And can a prolapse operation be done laparoscopically?
Yeah, it depends on what kind of prolapse you have. If you have a womb prolapse, the laparoscopic way of doing a womb prolapse operation is by use of mesh, which I was talking about. So that's called sacrohysteropexy. If you have a prolapse of the top of the vagina, which is coming out, then it's called sacrocolpopexy. So usually when you do the laparoscopy treatment of a prolapse, it is usually what is called with a mesh operation, and that can be done laparoscopically. But otherwise, most of the prolapse operation is done through the vagina. Some have done laparoscopy to what is called paravaginal repair, laparoscopic repairs. It hasn't shown to have any major benefit than the vaginal route, and that is not a standard technique to be done laparoscopically for prolapse of the bladder or the back wall. So vaginal routes are the standard routes. But if you're using a mesh for prolapse of the womb or the top of the vagina, then absolutely yes, laparoscopy can be used. And they're probably the gold standard to put the mesh in. But as I said, we don't do any mesh surgeries here at Benenden Hospital. And if you are considering having a mesh surgery, it is worth going for a person or a consultant or a unit which does regular meshes. And also they have a system in place where if there is a mesh issue, they can be sorted out at that place. Otherwise, worth knowing that meshes cannot be dealt at all the centers.
Thank you. And is a prolapse bladder repair risky if I already have a poor flow? Is it likely that I might need to have a catheter?
No, it's maybe other way around, to be honest. That if you have a big prolapse of bladder, that may be causing you the poor flow. And once we correct the bladder, then your flow might get better. So for correction of the flow, we don't have a problem. But if you're having, this talk is not for incontinence, but if you're having any incontinence surgery for incontinence surgery, then a poor flow can increase your chance of having catheter. But if you're having a prolapse fix, that it might increase your flow a bit better. And sometimes if you have quite a big prolapse and we correct it, it can sometimes unmask a bit of leak of waterworks as well. So just something to keep in mind. It doesn't cause leak of waterwork, but it can unmask a bit of leak of waterworks because prolapse can be masking the leak. But your flow might be better, to be honest.
Definitely. Yeah, and slightly linking into that, actually, this lady says that she's read before that urinary incontinence after an anterior prolapse, a bladder prolapse, can occur in 1 in 4 cases. And if it does, is it permanent or temporary?
Usually it's temporary and it gets better. But we have, I think we do more than hundreds of cases of prolapses per year. In my personal practice, I do more than around 200 cases of prolapse in a year, both in NHS and private sector. And I think after the prolapse operation, roughly around 1 or 2 of those, I may have to do an incontinence procedure in a year after. Obviously, if you have the incontinence symptoms beforehand, that's different. But developing an incontinence needing a surgery is around 1 in 2 every 200 cases I operate.
Yeah. And can you use vaginal estrogens if you're already taking HRT?
Yes, you can, because it is shown that sometimes you need vaginal estrogen as well after HRT, but it really depends on your symptoms, to be honest. And it's not automatically that you should have a vaginal estrogen. But if you're still symptomatic and you're examined by a healthcare professional and thought there's a lack of estrogen in vaginal area, you can have vaginal estrogen with combined HRT, but it's better to get checked first.
And if you have stage 2 prolapses, can pelvic floor exercise make it better, or is it just time until it develops into stage 3? So
Not necessarily. So stage 2 are the prolapses. If pelvic floor exercises help, there's other prolapses which it can help. And it's kind of we often get this other question asked that if I leave the prolapse, what happens? Is it going to get worse? It's like, how long is the piece of string? So your grade 2 prolapse may never get worse in your life, or you in a year's time you might have to see us because it goes progressed. So the answer is not necessarily it will go to stage 3. It may still stage 2. And if the exercises are done correctly, it might get supported a bit more and you will be less symptomatic of it. So, not necessarily it will get worse. If we take care of this, it might be chance that it may stay the same.
Definitely. Yeah. And if you have 3 areas of prolapse, so I'm presuming somebody's sort of saying bladder, maybe uterus, vault, or back wall, is it a more risky operation to fix all 3?
So it's not very uncommon to have all the 3 compartment prolapse. So sometimes you have 1 compartment, but usually when there is a prolapse, it either is a 2 compartment prolapse, or not unusually we have all 3 compartment prolapse. Whether it's more risky, obviously if you have prolapse of the bladder and we are fixing the bladder, there is no risk of injury to the bowel because bowel is away. So we consent the patient for risk of injury to the bladder. If you operate to the bowel, then there is a risk of injury to the bowel because of the back passage we are operating. There is no risk of injury to the bladder. But if you're doing both, obviously there is a risk of injury to bladder and risk of injury to bowel. But whether it increases hugely, I don't think that it increases your prolapse complications hugely. So if you have only 1 or 2 compartment prolapse, you may recover in 4 weeks. If you had a hysterectomy combined, you may need 6 weeks to recover. So yeah, slightly increased risk, but the risk of DVT, which is clot in the risk of infection, those risks remain the same with the operation you have. So yeah, slightly increased risk. More you do, more you have a risk. But I wouldn't necessarily say that you massively increase your chance of any complication than a background risk of having an operation.
Thank you. And should I continue my vaginal estrogen up to the morning of surgery?
Yes, you can. Absolutely no problem at all.
Lovely, thank you. So there's a question now, is it possible to see a nurse to teach pelvic floor exercises? The answer to that is absolutely. If you're watching this, I assume you're a Benenden member. You can use your Benenden membership to come just directly to the specialist nurses. That will open you a 3-month pathway that you can then spend with us. We can teach you to do your pelvic floor exercises, follow you up. Or if you feel that you have got maybe some slight incontinence or some prolapse symptoms, speak to your GP to get a referral here. And then obviously you'll be triaged to the specialist nurses as a first line, and then we can refer you on to the consultants if we need to in the future. So definitely utilise your membership to come and see us. And there's just a last couple of questions about patients who have got symptoms of prolapse and incontinence. And I would say on the back of that, you know, if you're worried about your symptoms, again, speak to your GP, get a referral to Benenden, and then a member of the team would be more than happy to see you. Sometimes you just need to assess patients on an individual basis, so it's difficult to answer those, but definitely use your membership and come along to see us. Thank you very much. If you could just move to the last slide for me, Mr. Gupta. Lovely, thank you. So thank you for attending this webinar, and I hope that we've answered all of your questions. If you provided your name and you've got any other questions, we will answer them via email. As a thank you for joining the session, we're today offering you a 50% off the value of your consultation and a callback from a dedicated private patient advisor. Tomorrow, you will receive an email with a recording of this session and further information, and also an update on news and future events. If you would like to discuss or book a consultation, the private patient team can take your call up until 8 p.m. tonight, or between 8 a.m. and 6 p.m. Monday to Friday, using the number that's on the screen now. We would be grateful if you could please complete the survey when this session closes to help improve future events. Our next webinar will be on cataract surgery, and you can sign up to this via our website. So on behalf of Mr. Gupta, myself and the expert team here at Benenden, I'd like to say thank you for joining us today, and we hope to hear from you very soon. Thank you very much. Goodbye.
Thank you. Bye-bye.
Bye-bye.